Welcome, everyone. Welcome to our webinar on maintaining quality with fewer resources, efficient approaches to malaria programming. We're going to be kicking off right away as we've got quite a full session today in our hour that's coming up, and there will be a Q&A at the end. Today's webinar is available in French and Portuguese, so please do select your preferred language option using the globe at the bottom of your screen. And for all housekeeping, you can refer to the chat where we will post instructions in English, French, and Portuguese. And with that, I would like to hand over to Malaria Consortium's Chief Executive, Dr. James Tabendarana, for the introductions. Over to you, James.
Thank you very much, Sam, and greetings to all of you, colleagues, friends, supporters, implementing partners, funders, donors, stakeholders. This is an important event for us because it tackles a topic that we are all grappling with. Today we have an exciting panel, an exciting moderator, Dorothea Chu, who is the team lead for tropical and vector diseases at the World Health Organization in Afro. She's going to be moderating the session, and we have three presentations that stand out to be very exciting. But I just want to take us very briefly, sort of into the bigger picture. I think all of us have experienced what's been going on over several years. I don't think it started just last year. We have seen over time the fact that foreign international development assistance for global health has been shrinking, and that has happened quite dramatically, I would say more so in the last year or two. And what it has meant is that we've all had to dig deep to figure out ways that allow us to continue to deliver quality programs more efficiently and to ensure that coverage is maintained for the communities that we all want to see free from malaria as well as the risk of malaria. And what these presentations are going to do is they're going to show us the adaptations and innovations that are taking place. So we're seeing programs innovate and adapt to our circumstance. And with these presentations, we will be able to have a discussion afterwards and see how this applies across various portfolios. So with that, I'd like to hand over to Dorothea Chu and to wish you a successful webinar. Thank you.
Thank you very much, James. Good afternoon, good morning, wherever you are, good evening. Let me just start by really congratulating Malaria Consortium for their leadership in not only implementing innovative strategies, but also sharing knowledge. Knowledge sharing, knowledge generation is very important at this critical time when we are all juggling to look for solutions on how to be more efficient. So today, as James has mentioned, we have a great a panel of speakers coming from 3 different countries with 3 different contexts. Again, I'm myself very delighted to moderate this. I'm talking from Brazzaville at the WHO Regional Office for Africa. So our webinar, as we see the title called Maintaining Quality with Fewer Resources, Efficient Approaches to Malaria Programming. Quite on point at this time where we go through critical gaps. The first panelist we're going to introduce is Gerson Affair. He's coming from the Mozambique program with Masters in Field Epidemiology and Laboratory. He currently serves as the Malaria Surveillance Focal Point in the National Malaria Control Program in Mozambique, of course. And his work centers on strengthening surveillance systems, using data for decision-making, and implementing strategies aimed at malaria elimination. He's authored a lot of scientific publications, and today he's going to be talking to us on a topic, strengthening data quality and use through locally led sustainable surveillance systems, the case of Mozambique. So, Gerson, if you're there, the mic is yours.
Okay, thank you, Dorothy. Hi, everyone. My name is Jason Afai from NMCP Mozambique. It's a pleasure to be on this webinar, sharing experience from Mozambique about how Mozambique implemented malaria surveillance in a different approach. So I'm here to share the experience, as I said, Mozambique setting and quality and use of local-led sustainability surveillance system. Next slide. Next slide, please. So between 2019 and 2022, the NMCP, with support of Malaria Consortium Mozambique, implemented a package of intensive surveillance settings interventions in which included data quality audits, supportive supervision. Can you go back, please?
Yes, we can hear you. Go ahead.
Yeah, go back slide. Okay, thank you. So as I said, a package of intensive surveillance threatening intervention in which included data quality audits, supportive reporting system, reporting data reviewed meetings, and self-decoy by the health facilities. So during the implementation of those intensive package, the in health facilities, a good data accuracy increased from the previous 45% to 84%. But after donor support ended in 2024 and 2025, this scenario reverted to 55%. This project was successful, improved the surveillance quality, but challenges remained to sustain those gains after the cut of support or after the ending of financial support. Next slide. So with all of the sustainability matters, we were called to rethink on how can we improve high quality of surveillance and maintain surveillance in a good quality under routine health system conditions. So because of a new approach was needed to extend not just think about defining dependence. So as always, we think about the declining support and the end of and the pressure to deliver good results with the limited resources. So we were called to think and shift from maintaining external funding activities to design surveillance process under routine health system conditions. And this process involves district, provincial level, and national stakeholders, and mainly to ensure a local ownership of all of the surveillance activities. And to do it, the district and provincial reviewed the findings from the project after donor support ended in order to identify the main local barriers and propose practical solutions. After that, everything was reviewed and validated, the main priorities, but we're all looking for the all needs at local level, especially at health facilities, because those are the one who produce data and implement the main activities of surveillance. Next slide. So after having all the main priorities defined, the surveillance interventions package was developed, a new one with a low cost, led by the districts, integrated, embedded with the routine health system, and led by the district level, as I said. So on this approach, the key activities consisted on strengthening the health facility, malaria focal person, implementation of self-decay with remote feedback using WhatsApp, as well as conduct virtual data review meetings, and so on. So those are the activities that we designed using the local staff at district level, provincial level, to have all of the surveillance activities going. Next slide. So after that, from the early, from the early results on the surveillance intervention package, we find a high acceptability of self-decay. Next slide. So on self-decay with remote feedback using WhatsApp and a message alert. So the Delta just send a pictures via using WhatsApp of the results of self-decay, and discuss all the findings from all of those decays with the district level as well, with the provincial level, using online meetings. And those meetings were mainly conducted monthly and involved, as it was a virtual, it was open to a large group of stakeholders. So as well as the extension of our integrated system which we call SISMA at local health facility. So instead of sending like the results from the reports, malaria monthly reports to the districts to introduce in the system, in some health facilities, the data was introduced, or the report were introduced locally using smartphones. But although this high acceptability of those interventions by the local staff, we are still challenging some difficulties, especially by the health facility staff.
Sorry, you have 2 minutes remaining.
Yeah, thank you. Especially on using digital platforms and participate consistently in a virtual meetings because of internet or that, and also on sharing airtime or that across all the programs. Next slide. So from those activities, we have some lesson learned. One of them is that the project significantly improved the data quality, but after the end of defining accuracy declined too much, but sustainability must be planned from the beginning. And also technical improvements require durable system change. So resourcing sensitive integration can generate substantial improvements, but maintaining these gains is difficult. And LO ownership matters from district teams are more likely to sustain solutions they help to design. And low-cost approach can strengthen surveillance. As I said when I was presenting, accountability and feedback mechanisms are critical during the all of activities, like strengthening malaria focal points is very important. as well as sustainability should be embedded in a routine health system process, as the goal is not simply to preserve previous intervention, but to build surveillance system that can continue functioning under routine health system, not depending on external findings. As a data use is essential for the impact improved data quality must be lead to action. And the routine data use is at all levels for decision-making, planning, and course correction is critical to improve program performance and health outcomes. Now, this was the last slide, and thank you so much.
Thank you so much, Kesson, for reminding us that we will not always have our donors with us. We need to use the opportunities of funding, current funding, to strengthen our health systems. Thank you for all the lessons using low-cost, local resources and very innovative ways to ensure that quality data is still available at all levels of the system. Thank you. If you have any questions for Gesson, please put them in the Q&A, and please just answer all the questions that you find there as we go along. We're going to pass through to the second speaker, and then we will take some questions at the end. So our second speaker will be Dr. Shikaru Emmanuel, the Deputy Director and Head of Case Management in Nigeria's National Malaria Elimination Program. He's an epidemiologist and malaria case management expert. So Emmanuel has many functions. He's been he's a peer-reviewed author of many publications, member of global technical groups, including RBM Partnership Working Groups and Chemo Prevention Alliance. His work spans on national guideline development, strategic planning, lots of things. And mainly, Emmanuel will be talking to us today about improving the efficiency and while maintaining the coverage of seasonal malaria chemo prevention in Nigeria. So SMC, how do we make it more efficient? Over to you, Emmanuel.
All right, thank you very much, Dorothy. And so I will be talking of some of the strategies we've been using to improve efficiencies in malaria programming generally, particularly in SMC in Nigeria. Next slide, please. So here it's just to tell us the Nigerian status as it pertains to prevalence. We have continued to record decline in prevalence due to deployment of high impact intervention, such as the chemo prevention, particularly seasonal malaria chemo prevention, because from the last malaria indicator survey we conducted, we saw that Nigeria has about 36 states plus the federal capital, that's 37, and we've seen the decline. A lot of the SMC implementing states have recorded decline in prevalence. And currently the country is at 15%, coming from the 42% we used to be in 2010. And currently, and it also varies across states, Lagos having the lowest, 2.6%, and the Ebonyi State at 1.2%, and this is due to deployment of some of this high impact intervention. For example, SMC alone last year, we reached over 28.5 million children, which is over half of the global SMC implementing countries. Next slide, please. So of course, some of the resource realities in Nigeria, as has been affirmed by the previous speaker, which is not also different from us, is the fact that there's reduced donor funding and competing health priorities, inflation and rising operational costs, especially in Nigeria due to rising dollar to naira exchange rates. We are continuing to experience that, and there's what we call the JAPA syndrome in Nigeria. That's human resource shortages, including retirements and other things. We Also, right now there's increased demand for, of course, integrated health deliveries and services. And so achieving equal or better malaria outcomes with available resources while maintaining service quality is key. And this has to happen through cost efficiencies, operational efficiencies, which we are deploying, for example, streamlining field logistics and programmatic efficiencies, as well as data-driven efficiency. Right now in the country, subnational tailoring, it's some of the approaches we're using to really target where these interventions are actually needed and not necessarily deploying the all-site fit or that used to operate. Next slide. So clearly, like I earlier mentioned, especially as captured in our current National Malaria Strategic Plan, we are deploying a targeted approach at implementing intervention through subnational tailoring based on local data, clearly, and even our National Malaria Indicator Survey. This time around, we're able to zero down up to the district levels, that's local government level, and also through proper coordination, site-wide approach, which has been the mandate of this current administration right from onset, ensuring that multi-sectoral alignment, then equity-driven focus on the vulnerable groups and internally displaced persons, as well as other measures of surveillance. Next slide. So like I mentioned, subnational tailoring, for example, in Nigeria, we have 36 states, and out of those, it's 21 states that are qualified for seasonal malaria chemo prevention. And even in those states, it's not all the district areas. So we are targeting, and other sister interventions are tailored towards other locations, amongst other things. So basically, those are some of the ways we have continued to use to ensure local data utilization, looking at local concepts, context, and optimizing both impact and financial efficiency. Like I already mentioned, site-wide approaches is one of the ways we are using to really ensure integrating public-private partnership, like ministries, civil society, under a single coordinated framework. And equity and gender, ensuring the vulnerables are actually really targeted for interventions. Next slide. So these are our 5 strategic execution targets, especially looking at the current National Malaria Strategic Plan 2026 to 2030 in Nigeria. Next slide. So some of the approaches, strategic approaches at ensuring, optimizing costs in deploying intervention. The seasonal malaria chemo prevention has been a major delivery platform, even for other health interventions in the country. We have continued to leverage and integrate intervention, and more so that SMC, having been scaled up since 2021 in Nigeria massively to 21 states, it has continued to gain that requisite platform to ensure integrated delivery of services. And you will see from this slide, SMC is, integrated with interventions like vitamin A, malaria vaccine, ITN distribution, routine immunization, and even TB screening in children, amongst several interventions. Also, we have continued to integrate even trainings across all intervention and program areas, and in supervisions as well are also really integrated in recent times in order to ensure efficiency in service delivery. The core benefit we are continuing to see is the fact that there is shared cost and improved service uptake and increased overarching efficiency. Next slide. Well, this is also just talking about what I talked about in the previous slide, so I will not really dwell much here. There's increased government ownership, by ensuring we share costs. When donors funds are brought, we also really earmark areas that the government in states and even national level really take care of certain cost areas, or also leveraging on existing program structures and amongst others. Also, very importantly, on the resource level, we try to ensure retaining persons that are really experienced so that we don't really have to spend much again retraining healthcare or service delivery personnel. There are also, in recent years, logistic and procurement costs have really been markedly reduced. For example, you don't have to procure certain things every now and then, and more so also we're tailoring towards technology, the digital solutions. Now the printing of papers and other things have really been greatly minimized in order to optimize costs of delivery of interventions, especially seasonal malaria chemo prevention in Nigeria. Next slide. Like I mentioned, also for commodity optimization, our quantification is strictly incorporated
You've
into
got
existing
2 minutes remaining.
All right, thank you. I'll just rush up. So this is also still talking about what I earlier mentioned. We're really reducing wastages, reducing printings, and avoiding unnecessary, areas of procurement in order to ensure the, existing implementation tools are reused where feasible, and training materials directly incorporated into quantification. Next slide. Use of technology has greatly increased accountability for us in deploying SMC in Nigeria, and has highly streamlined payment processes, which hitherto are usually oftentimes delayed. It has helped in supportive supervision, cohort tracking, even the tracking of commodities as well, which has greatly minimized diversions. And also mobile reporting and e-learning platforms have really, using technology, has greatly improved SMC delivery in Nigeria. Next slide. Also importantly, the health collaborative action effectiveness in Nigeria. We have the Nigeria's collaborative action strategy, and that platform alone has really led to great reduction in cost of in providing in interventions, including immunizations services, the SMC, ITN, and along other things that we have used the NCAS pilot in the country to really reduce cost of delivery of, so it's a major learning that we have seen in Nigeria. Next slide. So recommendations are the need to ensure we prioritize the use of malaria-burden data to target interventions precisely, and also integration is key. And we need to strengthen and expand integrated service delivery platforms.
Hi, Manuel, that's your time up if you'd like to wrap up.
Okay, I'm wrapping up already. This is the last slide. We need to deepen investment in community-level health system and improve end-to-end supply chain efficiency, deploy targeted data-driven supervision approaches, and also expand digital solutions across all program areas. Thank you so much for your attention.
Thank you so much, Emmanuel, for, lots of things to learn from there. You've succeeded to put that all in 10 minutes. And we're learning from your initiative on collaborative action strategy with all the partners you're putting together, really using health campaigns as a platform for bringing everybody together so that we communicate, plan, procure and manage campaigns together as a system. Thank you so much for that Nigerian's experience. So we'll take the last presentation coming to us from Uganda, and Dr. Rita Atgonza is here with us. She's a pediatrician and child health specialist at the I think she works with the Ministry of Health now with, she's currently working in the Vaccines and Immunization Division in the Ministry of Health, and Deputy Program Manager and Chair of the Service Delivery Pillar in the program she coordinates, and she supports health development partners at all levels in the country to ensure that immunization services reach every child in Uganda. Great, thank you and welcome, Dr. Rita. She'll be talking to us on driving efficiency through integration and really learning from lessons from the malaria and EPI collaboration and the vaccine introduction in Uganda. Over to you, Dr. Rita.
Thank you very much. I'll try to be very brief. So we're sharing lessons learned from collaboration and vaccine introduction in Uganda between the Vaccines and Immunization Division and the National Malaria Elimination Division in the Ministry of Health. So like all the countries that are represented here, malaria is a major public health problem in our country. And if you look at the map on my right, the eastern part of the country, Karamoja, actually has one of the highest prevalences of malaria in children, the Karamoja sub-region. And this is a region that we work together with Malaria Consortium to support the elimination of malaria. And in particular, the intervention that has been introduced in this region is seasonal malaria chemo prevention. Now, in particular, together with Malaria Consortium, we're implementing the Send Malaria Vaccine Project to increase uptake of the vaccine in all 9 districts of Karamoja that are already implementing seasonal malaria chemoprophylaxis. Integration is a key agenda for the Ministry of Health, given especially the current fiscal landscape. So in 2025, in April, we introduced the malaria vaccine in 105 moderate to high burden districts out of the 146 districts and cities in the country. So we introduced the R21 matrix, and the age group was 6 to 11 months. This vaccine is given at 6, 7, 8, and 18 months for all 4 doses. And we worked with partners, particularly Gavi, that supported 85% introduction across the country, as well as WHO, UNICEF, World Bank, PathChai, and Malaria Consortium that supported technically, procurement, supply chain, and introduction across the entire parts of the country. So shortly after we introduced, we started, of course, the process of evaluating the coverage. This malaria vaccine was introduced during the Integrated Child Health Days, which are held biannually in the country. These are the months of April and October where health workers go out into the communities with a package of different services. So this was the perfect opportunity to introduce this vaccine in a new age group. We had very high demand for the vaccine. Health workers were giving it even to children who were beyond the age group 6 to 11 months. So we had coverages above 100%. But if you note, there was a subsequent decline in the second and third vaccine coverages for the malaria vaccine. And of course, this is because this is a new behavior, expecting health, mothers to come to the facility outside of the traditional window for vaccines. So we also have challenges affecting the second year of life platform, particularly, of course, like I said, the caregiver knowledge gaps, understanding the new schedule for the malaria vaccine, and working with partners and, especially with WHO, where we did formative evaluations periodically. And we were able to address some of these gaps. And as of April of this year, we've seen that there's actually an increase in the second, third, and fourth doses of the malaria vaccine. So why the Send Malaria Vaccine Project with Malaria Consortium? So while we had that initial uptake, of course, like I've shown you, the cascade was not as good for the subsequent doses. And Karamoja sub-region in particular faced greater difficulties with very high dropout rates. So this vaccine project was launched with the key objective of strengthening the technical capacity, but also coordination at all levels, but ultimately to ensure that we were increasing the vaccine uptake at community level. And we covered all 9 districts in the region. Karamoja is a very unique region. It borders Kenya. It's very highly nomadic. It's a pastoralist population. It has severe resource constraints and very minimal healthcare, but also other infrastructure in place. So we tailored our service delivery specifically for this region. We piggybacked on existing interventions, specifically the seasonal malaria chemoprophylaxis, and also the integrated child health days, which happen every April and October. So we leveraged the mobile village health teams and adapted delivery because the pastoralist homes are mobile, but also really widespread. So we leveraged the existing networks that have been developed in previous work done. And then, of course, we engaged their cultural, religious, and political leaders very early on in planning to ensure that we had public endorsement and also trusted leaders to reduce vaccine hesitancy. So what we utilized was the supermarket approach. Working with Malaria Consortium, we integrated malaria and child health delivery in this region. So this is one trip with multiple protections, one team of health workers, ensuring that we give seasonal malaria chemoprophylaxis to eligible children aged 3 to 59 months, malaria vaccination for children who are due for a catch-up dose, catch-up vaccination for 0 dose and under-immunized children, nutrition screening, insecticide-treated net ownership and use assessment, and then, of course, malaria prevention and caregiving counseling. And during these approaches that were done during the integrated child health days, we had about 3,100 children receive multiple services. This is the same family, the same child that we are targeting. 41% of children received multiple services, and 97% of children were able to get the entire package. So this is just really a synchronization, different activities that we did to ensure that demand creation and community outreach was leveraged in every platform, right from the district with the leaderships, planning, line listing, working with health facilities to line list the children who had missed their doses, mobilization and demand generation, and then ensuring that health facilities led community outreaches and dialogues. And these are the results. What you're seeing is a comparison from April-December 25 and Jan-April 2026. So while we see this initial decline in the first dose of malaria vaccine, that's because we were now following guidelines. Like I said earlier, there was such enthusiastic demand for the first dose that it was given to children outside of the recommended age group initially. But what's quite impressive is that we saw an uptake in the 2nd, 3rd, and 4th doses of the malaria vaccine, which has greatly improved the cascade.
Hi, Dr. Reed. You've got 2 minutes remaining.
Thank you. This is really just a graphic presentation of the results showing the improvement in the cascade of the malaria vaccine. So these are some of the lessons that we've learned and that we are integrating across the rest of the country. Just like the previous speakers, we've noted that new health interventions are more sustainable when we embed them within the existing health system. We need to work with non-health governance structures to improve coordination, accountability, and ownership in the community. Integrated community engagement is more cost-effective and impactful than parallel approaches. And we already have existing systems that provide a strong platform for introducing and scaling not just other vaccines, but other products. For example, insecticide-treated nets, nutrition commodities, and SMC. And then, of course, integration strengthens both the new intervention and the underlying health system. So this creates long-term benefits beyond just the initial introduction. So our expectation is that in this particular region, as we continue with this project, we shall see sustained gains because we are working with the existing health system. So I just want to acknowledge our partners, especially the subnational level, the health and district local governments, Malaria Consortium, both the UK and Uganda team members, our health workers, our community members that we wouldn't be able to work without, and of course the bigger Malaria Consortium family. For God and my country, thank you very much.
Thank you very much, Dr. Rita, and very good lessons there. The need for collaboration across programs, actually showing that it's a win-win for everybody, both for existing interventions and for newly adopted interventions we are rolling out. Everybody gains by working together. Thank you for that example. And there are questions coming up. Thanks for using the Q&A to share your questions. I've seen it's very active already. I hope you can access it, everyone, so you can also learn from other people's questions and answers. But now we are moving into the Q&A session. I think it's 10 minutes for Q&A, and we're going to try to flag some of the questions which we would like to bring to the panel. First of all, I think we'll start with the surveillance bit. I would like to just call out one question that came up in the chat on how do we ensure that we do not go back on the progress achieved.
Okay.
The funding will keep going down. How do we ensure that these interventions you're putting in place are going to be sustained and that they're going to give the same results and they could be scaled up? What are the things you're doing to get you to that level with less resources, of course?
Okay, thank you. So I think that on my point of view, I think that having the same results will be a little bit difficult, but what we mostly do or we have to do is to look for local initiatives. Like as I said, in Mozambique, what is implemented in 4 provinces, they have their own way of looking for data. It's like let's say something new, and it's not implemented around all the country. So it's like all of those interventions are implemented locally, and at local staff which implement like data discussion, self data quality review. So if we ensure that the local staff from that facilities, they do their self-decay and they report to the central level or provincial level, it shows that they are interested in having good data, for example, and it will make us have good decisions. So on my point of view, looking for our experience, if we ensure that they discuss, they share the result of the data discussion, we'll have those results. We ensure that are good. Of course, that the central or provincial level must do like a supervision or regular supervision, but that is not because of the financial conditions, not possible to do frequently. But if we ensure that local staff knows their role or responsibility on data production, reporting, and everything, we can maintain the gains. Not like the same, but on a new approach.
Thank you. Thank you. Yeah, thanks for bringing out that aspect of self-empowering the local staff. So they themselves should be, their capacity should be built, in using the data and also reviewing the data themselves even before reporting. I think that point you made, Gerson, is well taken. There is a question, I don't know whether another person wants to talk on this. I'm seeing a hand, but there are 2 other questions on the chat. Let's probably get some contribution from Sonia, and then we take the 2 other questions from the chat. Sonia, you want to come in?
Yes, thank you. So I'm Sonia Nos, the Malaria Consortium, Mozambique. I wanted to add on Gerson's answer and say that one lesson that we had from this project is that to have the ownership from the district. So after the donor withdrawal from the first project, we started with this project to understand the challenges, and based on the results, including the DQA, we had meetings at different levels, starting with the district level, health facility level, and also with the province, and later with the NMCP to discuss local decisions. So these are decisions made by the staff, by the districts, and we think that this is one of the way for sustainability. Thank you.
Thank you very much, Sonia. So there's one question from Elijah Ochele for Emmanuel. So the question is this: does your new strategy of retaining only the old personnel to reduce training costs owing to the low funding resources ultimately mean that prospective new entrants and highly skilled professionals like me who are passionate about the malaria elimination program in Nigeria will not be able to do so? Training and containing is a core element in the elimination program. So that's sustainability. And yeah, ahead to you, Emmanuel, please.
Oh, thank you very much, Elijah, for the excellent question. So basically, what I was referring to in that presentation is around the deployment of seasonal malaria chemo prevention in Nigeria, where we have primarily more of like volunteers, but really provided with some level of stipends to deliver SMC in the eligible regions or areas of the country. So over the years, like I mentioned, we have gone at scale to 21 states in the country from the previously 9 states. And since 2021, we have continued to engage service delivery personnel, some of them already employed by the government, that's health facility workers and the state officials and national officials. Those ones are primarily employed by the government and partners, while the community delivery personnel are more of like ad hoc staffs that provide this support. So over the years, they have been receiving trainings, and a number of them are still very much visible because we utilize people who are based in those locations. So in order to minimize cost of having to train every year new personnel, we have worked closely with the subnational officials, states, and even district or local government areas to ensure that those service delivery personnel are retained as much as possible in order to minimize having to train for the previous 2 days that we often do before now. And now we have been able to reduce to 1 day because a number of them are very much experienced. They have been deploying this intervention over the years and all of that. And back to your, clarity or query, of course, we want high-level professionals like you to provide support to the national program. We have a number of volunteers, and in whatever way you want to support based on your location, sure, we are disposed to having such support as it were. But depending on what exactly you mean, or however, as a professional ready to render services to the malaria programming, because of course we really require technical expertise in supporting malaria intervention in the country based on your strengths. Thank you, and over.
Thank you very much, Emmanuel. Yes, the training part is usually challenging, so thanks for addressing that. There are 2 questions for you, Dr. Rita. One is, Well, I think it could go also for Dr. Emmanuel. As a National Health Fellow here in Nigeria, I noticed that the SMC program, aside the SPA cure, which is the SPAC, the drug, being distributed, vitamin A supplement is also distributed. What's the link between malaria prevention and vitamin A? And then the second one, I'll read it so that you answer both. I think it comes from Rashid Mohammed. Very well, Rita, on the segment around pastoralists in a Karamoja, I think, region. Please, is it possible you speak to challenges in dominated pastoralist region? What is the uptake like for vaccine compared to the country national coverage? So those were two questions. And then the last one for Rita is about I think there were two. Okay, that's fine. It seems it's a similar question. Go ahead, Rita, please.
Hi, Dorothy. Sorry, just to say there's about 2 minutes left of the Q&A. So just to
yeah, thank you. So 1 minute for each. Anybody wants to add after Rita?
Thank you very much for those questions. I'll start with the second question because I have a visual for it. So if you look at the area I was describing, Karamoja, it's the area on the right of the map. It is, it borders with our neighbor Kenya, and we have a predominantly pastoralist community. So I just wanted to show you how low, how high the prevalence is for malaria in that region. But when we look at the coverage as well for vaccination, it's equally low. So, which really shows that the way of life, but also the health systems set up in this region has quite a bit of challenges that I highlighted earlier. So we have high prevalence of malaria and also low coverage for immunization and other child-related service delivery in that region. And I think we're all familiar with the challenges of the numbers. They move a lot, they're a bit isolated, still very much rooted in cultural beliefs that drive their local practices, very mistrustful of the government and government, service delivery structures because of, historical, the relationship between vitamin A and SMC. Vitamin A, for those of you who remember, is used to prevent childhood blindness, the retinopathy. I think that's associated with vitamin A deficiency. And we first give this vitamin supplement to children aged 6 months and then at 1 year. The relationship with SMC is that we use the same platform to give these two medicines to children. So we have integrated child health days where we go out into the community in April and October. And we utilize this platform to give all these services. They get the vitamin A, they check for their nutritional status, they get their seasonal malaria prophylaxis. If their vaccines are not up to date, they're also given. So it's really just different mechanisms, different reasons, but given at the same time for efficiencies. Thank you, and back to you, Chair.
Thank you, excellent. I think that really wraps up. The child needs these different interventions to improve their survival due to the high comorbidities that we have. Thank you, Dr. Rita. So we have a last question, but we have just 2 minutes. I'm wondering whether we can take that last question on how to mobilize resources. But I can just speak to that. Do you want 30 seconds, Posse? And then I wrap up for a few minutes, and probably, I don't know who wants to address the resource mobilization question, but I could also wrap it up in the closing. And I saw James' video. Maybe he wants to say one last word just to finalize. But Posse, 30 seconds, and then James, and then we finalize this.
Yeah, thank you. I just wanted to supplement on Peter, but there was a question which was asked by Edwin. I thought I should assist Rita to respond to it. He asked about substitution tendency where parents would want to vaccinate and after vaccinating they forego other preventive measures. The way we prevented this was that we sent out integrated messages that was encouraging mothers that no single intervention preventive measure is adequate, is enough, and therefore one needs to sleep under net, one needs to get chemo prevention, and one needs to have a child who is vaccinated. It was integrated message during the introduction, and mothers got it that way. And secondly, when they are out for SMC, when they are screening, they first check whether the child is sleeping under a net, they check whether the child is vaccinated, and if the child is not vaccinated, the child is supported to go to a nearby outreach to get the vaccination, so that the three measures, SMC, net use, and the malaria vaccine, they go hand in hand. So that's what I just wanted to add on Rita's message. Thank you.
Fantastic. Thank you so much, Posi. And over to you, James.
What I want to do is to thank all the participants who have spared their time to listen in. Dorothy, for your amazing moderation, and the presenters that have brought the message to us. I think it is clear that with the new era we're facing, we need to be dynamic, we need to be adaptable, we need to stress local ownership. Thank you very much.
Thank you very much, James. And so we need to also take over the mobilization of resources. So thanks for that final questions. Let's continue to show that with the little we have, we can have good results. We make a case, we make a good case for the governments to continue to invest in health and in malaria. So thank you very much. We continue some of the time, and we hope you learned one or two things here. Thanks, Malaria Consortium, and courage as you continue the projects. Bye, everyone.